Thank you very much, ladies and gentlemen. I have to find, okay. The radioembolization is an innovative treatment of liver tumors and metastases using intraarterial infusion of yttrium-90 microspheres through the hepatic artery into the liver tumors and metastases. They are the microspheres, and we inject them through the hepatic artery directly to the liver and directly to the metastasis. With these microspheres, you can embolize the blood feeding vessels of the tumors, and also in this site radiate the tumors very targeted. Yttrium-90 microspheres is an approved treatment by FDA, but however there are other radioactivities like holmium-166 microspheres, rhenium-188 microspheres, and also phosphorus-132 microspheres, which have been used for radioembolization. There are two different products, yttrium-90 resin and yttrium-90 glass microspheres. The mean diameter of microspheres is about 30 micrometer. As you know, yttrium-90 is a pure beta emitter with a half-life of 64 hours, and the tissue range penetration of yttrium-90 in the mean tissue range penetration is about 2.5 millimeter. Therefore, you can perform a targeted therapy and save the healthy liver tissue. As you see here in this slide, it's a microdosimetry in liver explant done by Andrew Kennedy, and they showed in this tumoral tissue, you can achieve at least a dose of 100 gray, the blue line, in the tumor, and in some regions, the green lines, you can achieve up to 200 gray, and the blue and the red regions, in these regions, they achieved 1000 gray. And such a high dose you cannot achieve with external radiotherapy of the liver. As I mentioned before, there are two different products. One of them is the resin microspheres produced by Sirtex Medical Company in Australia, and the other one, glass microspheres produced by BTG, called also Therasphere. There are some differences between these both products. As you see here, one of these differences is the number of microspheres. As you see here, the number of microspheres in the case of resin microspheres is significantly higher than the number of microspheres with glass. And also, the amount of radioactivity in each sphere is in glass microspheres is 50 times more than resin microspheres. What are the requirements for radioembolization? First of them, liver-dominant disease, a good hepatic reserve function, especially the bilirubin value should be under 2. The performance status of the patients is very important. The ECOG should be under 2. And if this procedure is technically feasible. Therefore, normally the radioembolization have two parts. The first part is the simulation part. The radiologist with a catheter try to find the feeding vessels of the tumors, and perhaps they coil embolize some vessels which go to other organs like stomach or duodenum. And after that, we inject technetium MAA for simulating the real treatment, for evaluating the activity distribution in the liver, and also to rule out any extrahepatic accumulation. And also a lung shunt is very important. After that, we can make a dosimetry, and we calculate the dose, and we are going to do the treatment in another session, normally 1 week or 2 weeks after the first session. And you see here 2 different boxes of Sirtex for racine microspheres, and the other one is for glass microspheres. There are a lot of publications with different tumors, but today I'm going to focus on HCC and colorectal cancer. Let me start with HCC. As you know, for HCC, there are different staging systems, but BCLC from Barcelona is one of the most important and useful staging systems for HCC. And as you see here, there are different stages, stage BCLC A, B, and C, and also terminal stage D. And for each stage, they recommend specific treatments. We start with stage A, earlier stage disease. And you see here, they recommend for stage A, liver transplantation, liver resection, and or a local treatment via radiofrequency ablation. But for patients who are waiting for liver transplantation or could not be treated with a curative intent by resection, transplantation, or ablation due to age, portal hypertension, tumor location, or other comorbidities, you can use a radioembolization as an alternative therapy, and the median overall survival after radioembolization is about 26 months. What is with the stage B disease? Stage B, the recommended treatment is transarterial chemoembolization, but if you take a look at the results of radioembolization in stage B disease, I am going to show you the results of 2 studies, one of them done by racine microspheres, other one by glass microspheres. It's published by Zangro. And you see here for BCLC-B, the median overall survival was about 17 months, and with glass microspheres also the same median overall survival, 17 months. And if you see here, the overall survival actually with radioembolization was better than TACE, but these differences were not significant, and the radioembolization seems to be more tolerable than TACE. But not all patients in the intermediate stage BCLC-B are considered good candidates for TACE, for transarterial chemoembolization, especially the patients with bulky disease confined to the liver and who have failed TACE, the patients who had received 2, 3 to 5 times TACE, but without response. You can use also for intermediate stage the radioembolization for downstaging. You can also use the TACE. But in this publication from Lewandowski from Riyad Salem group, you see here that yttrium-90 for downstaging was significantly better than TACE, and the patients were downstage from T3 to T2. And also the median survival of these patients with radioembolization was better than TACE, and this difference was significant. Now we move to stage C, advanced stage. And for advanced stage, the recommended therapy is the sorafenib. Based on the positive randomized control trial, sorafenib is the recommended treatment, as you see here. Especially based on this published study, you see here sorafenib compared to placebo, 3 months longer overall survival, and after that sorafenib has been recommended for treatment of BCLC disease. But up to 40% of patients do not tolerate sorafenib in clinical practice due to adverse events. And again, these Kaplan-Meier curves In BCLC disease, patients showed 10 months overall survival under radioembolization, and with glass microspheres also 7 months overall survival. But I have to mention here, for child A liver disease, 14 months, and for child B liver disease, 6 months. And I have to mention here that the sorafenib study patients also had a child A liver cirrhosis disease, not child B. One of the other advantages of radioembolization versus TACE is that you can use radioembolization for patients with portal vein thrombosis, patients who have a portal vein thrombosis are in BCLC-C group, and especially in child A liver disease, the results are good. There are some ongoing studies. For example, the SARA study. In this study, there is a head-to-head comparison between sorafenib and treatment with radioembolization with racine microspheres. And let me summarize the HCC. As I show you, at the moment, the guidelines recommend these treatments for HCC in different stages, but you can use also radioembolization as an alternative therapy. Now, some examples. The CT scan of a patient with child A liver cirrhosis, a very huge liver tumor, as you see here in different sections. We performed the treatment 2006, and you see here in this section, in this slide, prior to the treatment, the big tumor, alpha-fetoprotein, was more than 3,000, and 8 months after the treatment, alpha-fetoprotein was unremarkable, and the tumor shrinkaged, as you see here. I am going to show you the next slide. After 22 months, no tumor, complete response. Another slide from this patient, prior to treatment, this huge tumor, 8 months after the treatment, and again, 22 months after the treatment, no tumor, complete response. The patient died 6 months ago because of lung emboli, but not because of liver cirrhosis or tumor. Now the colorectal cancer. You know, the majority of patients develop hepatic metastasis. Surgical resection and ablation are the treatment of choice for hepatic metastasis of colorectal cancer. But as you know, the majority of patients are not, cannot be operated because they have multiple metastases or other metastases. And there are different lines of chemotherapy like FOLFOX, FOLFIRI, 5-FU, and the question is when we can use radioembolization for these patients. You can perform radioembolization for liver metastasis of colorectal cancer in different settings. The majority of published studies, they used radioembolization in salvage setting. But you can perform radioembolization also as first-line or second-line therapy in combination with chemotherapy. You can also use radioembolization for downstaging prior to a resection or ablation. First, salvage therapy. You see here some results of salvage therapy with treated with radioembolization. The patients who were chemo-resistant, and you see here a median overall survival in about 10 months and an overall response rate from 10 to 40%. Let me show you one example. It's a PETCT scan of a patient with multiple liver metastases and also some extrahepatic metastasis, here lymph node metastasis and a bone metastasis. But as you see here, he has a liver dominant disease. we performed the radioembolization, a whole liver treatment in one session, and 4 weeks later we did the follow-up with PET-CT. You see here a complete response, but the lymph node metastasis is still there. The bone metastasis showed here some progress, but a very good response in the liver. Another slide from this patient, a transversal section prior to the treatment, 4 weeks later after the treatment. Therefore, we think you can use FDG PET-CT for the follow-up of these patients, especially 4 weeks after the radioembolization. Now, some results. The difference between responder to radioembolization and non-responder to radioembolization, and also comparing with historical controls. You see here the publication from Kennedy showed 10.5 months overall survival. Jacobs from Germany also 10 months survival. Cosimilli 30 months survival. It means this treatment is a useful treatment for these patients. Another example, a female patient with multiple liver metastasis of colorectal cancer. We performed first a technetium-MAA scan. You see here very good tumor accentuated uptake of technetium-MAA, exactly like the FDG PET-CT. We performed the treatment for the right liver lobe with 500 megabecquerel racine microspheres, and for the left liver lobe with 200 megabecquerel. Here you see the bremsstrahlung SPECT-CT, very good accumulation in the tumoral area, and we did 4 weeks later, 4 weeks after the treatment, the PET-CT, you see a very good response. PET-CT 3 months later, good partial response. 6 months later, no tumor. 9 months after the treatment, the patient developed new metastasis. It means 9 months progression-free survival for this patient. But you can use the radioembolization as first line or second line therapy, which is actually more helpful than salvage treatment, especially if you combine radioembolization with chemotherapy. I'd like to show you this slide. This is a study done by Professor Gulek. They treated patients with chemotherapy as the first-line treatment, and they treated just one lobe of the liver with the radioembolization. Here, for example, you see multiple liver metastases, and 4 weeks after the treatment, they performed again FDG PET-CT. And you see here the right liver lobe treated by radioembolization and chemotherapy, and the left liver lobe just the chemotherapy, and you can see the better effect of a combination therapy with radioembolization, chemotherapy plus radioembolization. There are also some prospective studies, published data, who used radioembolization as first-line treatment with an overall response rate between 40 to 90% and a median overall survival of about 2 years. And also using radioembolization as second or third-line treatment with an overall response rate of 30 to 50% and 12 months median overall survival. There are also a lot of ongoing studies in this regard. One of them is the Cirflox study. We are all awaiting of the results of Cirflox study. Next year actually should be published. And you see here in this study, they compare using radioembolization with racine microspheres combined with FOLFOX with or without bevacizumab, compared with chemotherapy alone. What is with downstaging? With radioembolization, we see a very interesting effect. Sorry, here. Okay. We see a very interesting effect. If you treat one lobe of the liver you induce a hypertrophy in the contralateral lobe. As you see here, different studies which showed this effect, and this hypertrophy can be detected actually after 4 weeks, up to 6 weeks. One from our department, we treated the patients just in the right liver lobe. After 4 to 8 weeks, we did the follow-up, and as you see here, median hypertrophy in the left liver lobe was 34% in a median follow-up time of 1.5 months. Let me show you one example from this study. A 80 years old female with colorectal cancer and some liver metastases, as you see here in this slide. We performed for the right liver lobe a radioembolization with 500 MBQ Racine microspheres. They are the scans, the CT scans prior to SIRT. 5 weeks later, you see a partial response in the metastasis and about 81% hypertrophy of the left liver lobe. 3 months after that, the patient received an operation, the metastasis, a hemihepatectomy of the right liver lobe, and this is the scan 3 months after the operation, and you see a further hypertrophy, but it is also because of the operation. And histopathology showed 2 necrotic metastases with some vital tumoral cells. It means the operation was very useful for this patient. Let me summarize the results and the utility of radioembolization in colorectal cancer. It is the recommended approach for the treatment of liver metastasis of colorectal cancer, first-line chemotherapy, second-line, if they are not resectable, and finally, for chemorefractory patients, a radioembolization. But you can use also SIRT in combination with chemotherapy as first or second line or nth line chemotherapy plus SIRT, or you can use SIRT as consolidation therapy between 2 chemotherapies for a chemotherapy break. And now I'd like to show you some other utilities of radioembolization. You don't have to use it just for a liver. You can use it also for other tumors. There is a publications case report from Riyad Salem group. They used radioembolization for renal cell carcinoma, and they wrote the 2 main indications include controlling operative blood loss during nephrectomy and for palliation in the setting of unresectable tumors. There is also an ongoing study called the RESIRT study, renal SIRT study, and the primary endpoint of this study is the safety, toxicity, and maximum tolerated dose, and the secondary endpoints are tumor response rate, progression-free survival, quality of life, and overall survival.
You have 2 minutes to conclude your...
Okay. In Germany, in Magdeburg, they performed radioembolization for lung metastasis, and they showed that here in this slide, they treated just the left liver lobe in both patients, and as you see here, 5 or 6 weeks after the treatment, you see partial response and also a stable disease after radioembolization of lung metastasis, but the non-target lung metastasis in the right lung showed a progressive disease. It means radioembolization is effective and can be used for good selected patients. And also, KO used radioembolization for an adrenal cyst. You see here the PET scan, yttrium-90 PET scan after radioembolization with a partial response in follow-up. Thank you very much.